thank you so much for joining us for the second Neonatal Kidney Collaborative Virtual Symposium on the Basics of Neonatal Kidney Health. My name is Jennifer Jatan. I'm coming from the Medical College of Wisconsin and Children's Wisconsin in Milwaukee. And on behalf of my Education Committee co-chair, Dr. Allison Kent, our program coordinator, Megan Reagan, and our fearless leader, David Askenazi, and the steering committee of the Neonatal Kidney Collaborative, we'd really like to welcome all of you and thank you for being here with us today. For those of you who are not familiar with the NKC, we are a multi-center, multidisciplinary, multinational organization dedicated to improving the health of newborns with or at risk for kidney disease through multidisciplinary collaborative research, advocacy, and education. We started in 2013 as a group of 9 people just sitting around a table talking about how we could work together to improve care for babies and baby kidneys, with the one stipulation being that the work would have to be done through collaboration between neonatology and nephrology. Today, our group includes 301 people from 152 centers around the world. And truly, the NKC is a community of people passionate about working together to help our patients and to help each other provide the best care we can. Last year, when we first talked about doing something like this, we thought we would have 20 or so participants if we were lucky. Instead, we had over 600 participants from over 60 countries. There have subsequently been over 1,000 views of last year's symposium on the YouTube channel. And today we are thrilled to have over 400 of you from 297 unique institutions registered and here with us. So our attendees include medical professionals at all levels and in all roles, and we see all of you as a part of the neonatal nephrology community and hope that in addition to learning something new today, you identify new connections, collaborators, and friends. And so a few words about the day. We have 4 fantastic speakers, and each speaker will be introduced by a member of this year's 6-2 crew. And for those of you not familiar with the 6-2 crew, this is a longitudinal mentorship program in the NKC for trainees at any level with an interest in neonatal nephrology. The purpose of the program is to provide early exposure to the work of the NKC, involvement in the committees, and networking opportunities. And this year's nine interns were selected out of a very competitive pool, and we're excited for you to meet today the 3 interns who are currently working with the Education Committee. So if you are a trainee out there participating today, consider applying for this program when the applications open up next year. We would love to talk to you. So each talk will be 25 minutes, followed by 5 minutes for question and answer. Please write any questions you have in the chat, and Dr. Kent will monitor the chat box and present the questions to the speakers at the end of each talk. If there are more questions than time available, the speakers will submit answers and the responses will then be sent out to all the attendees at a later date. Unfortunately, we will not be able to have live interactive discussions on this platform. We will provide contact information for our symposium participants if you want to email questions after the fact. If we don't know the answers, we will try to put you in contact with someone who does. So we certainly recognize there are a lot of ways of doing things and lots of different clinical settings with different types of resources available. We've done our best to keep the content as broadly applicable as possible. All the talks will be recorded and posted on the NKC website so that you can access them at a later date. And at the end of each talk, you will see a QR code. Please use the code to respond to questions based on the content and learning objectives of each talk. We will also send out a post-symposium questionnaire evaluating the whole symposium. We very much value your feedback. All of the talks today were selected based on the feedback and suggestions we received last year. Similarly, if you have not filled out the pre-symposium questionnaire and you have the ability to do that rather quickly, we would appreciate that as well. Like last year, we're giving away 2 free registrations for the NICS course in Birmingham, Alabama. The winners will be announced at the end of this session, so stay tuned for that. On a personal note, we wanted to say a word about our mentor, NKC enthusiast and dear friend, Dr. Patrick Brophy, who passed away a little over a week ago from lymphoma. Yeah, I thought I was going to be able to get through this. Okay. He was my first boss. He connected me with Dr. Askenazi during my first year on faculty at the University of Iowa, and is truly the reason I've been able to do the things I've done in my career. Dr. Kent was Dr. Brophy's first hire at the University of Rochester, and he helped connect her to the NKC group and supported her ongoing neonatal nephrology research. And even more broadly, Dr. Brophy was critical to the formation of the NKC, giving Dr. Ashkenazi the confidence to get it started, making sure it was great for the kids and doing it in the right way every time. Really, he elevated everyone he met, whether or not he had known you for a day or 20 years, he would do whatever he could to help get you where you wanted to go. He lived his life with joy, humor, passion, love, and most of all, commitment to the kids, and we will all miss him terribly. Finally, we at the NKC want to acknowledge all of the suffering that many are experiencing right now, and we continue to hope for peace around the world. Again, always time to have a moment of gratitude for being able to be with all of you today. All right, so thank you again, and let's get started with our first speaker. I will turn it over to the 6-2 crew member and future neonatologist, Dr. Miranda Deitmeyer.
Thank you, Dr. Jatan. Hi, everyone. Like she said, my name is Miranda Deitmeyer, and I have the privilege of being one of the 6-2 crew interns at the NKC this year. I am currently a third-year pediatric resident at the University of Iowa and will be pursuing a neonatology fellowship next year. I have the great pleasure of introducing our first speaker today, Dr. Kat Gist. Dr. Gist is an associate professor in pediatric cardiology and intensive care in the Department of Pediatrics at Cincinnati Children's Hospital. She led the worldwide exploration of renal replacement collaborative in kidney disease, as well as the kidney interventions during membrane oxygenation collaborative. She's a proud member of the NKC and has participated in the first Pediatric Acute Disease Quality Initiative. Please join me in welcoming Dr. Gist for her lecture on neonatal AKI, fluid imbalance and overload.
Thank you, Miranda, and thanks to the NKC for Education Committee for inviting me to present on this topic. I have a couple of disclosures, or 3 disclosures, but none of them are relevant to the content of this presentation. So the objectives over the next 25 or so minutes are to define disorders of fluid balance in neonates, describe the challenges of assessing fluid balance in neonates, and finally describe the impact of pathologic positive fluid balance on clinically relevant outcomes. Recently, the Acute Disease Quality Initiative working group convened to develop consensus statements on fluid balance. Many terms have been used imprecisely to assess the impact of fluid volume on outcomes in sick children, including fluid balance, fluid accumulation, and fluid overload. Fluid overload has certainly been conflated to describe both the degree of positive fluid balance within a patient and its association with adverse outcomes. And use of the term in this manner really introduces bias into research and clinical practice, and it presumes that any degree of positive fluid balance is synonymous with fluid overload and therefore is detrimental. Such use presumes that net fluid removal and targeting negative fluid balance is beneficial, although we all know this is not true. So fluid overload is then a distinct pathologic state of positive fluid balance associated with adverse consequences. Fluid balance is an objective calculation using specific methods, and we suggest that the term cumulative fluid balance be used to describe the previously referred term fluid overload to separate the pathologic state from specific calculations. And this term daily fluid balance, cumulative fluid balance, and percent cumulative fluid balance describe states of patients for the purposes of clinical care and research. And so taking that slide into a visual construct for you, as we think about the spectrum of fluid balance, first focusing on figure A. There's a spectrum, and that can be seen in this figure, of a U-shaped curve where extremes of negative and positive fluid balance, think volume depletion in a patient with severe diarrheal illness, and on the opposite end, fluid overload, think about the patient with heart failure or nephrotic syndrome as examples. It is important to realize, however, as highlighted in figure B, that there's a spectrum of fluid balance that varies significantly by case mix, resources, and tolerance of the individual, and that an individual's threshold of when positive fluid balance becomes pathologic will vary by case. Thus, there is no distinct point at which a positive or negative fluid balance becomes fluid overload, so the positive component of that, despite how we define this oftentimes in clinical research. Lastly, in figure C, this is meant to highlight some of the patient factors that contribute to both volume depletion and fluid overload, and suggestion of specific interventions that might be used to counter these effects. The challenge of assessing fluid overload or the challenge of assessing volume in children, particularly preterm and term neonates, is that children in general have a large proportion of fluid to body weights, at least compared to adults, representing upward of 85% in preterm infants and approximately 85% in the term counterparts. As shown in the figure on the left, you can see that the total body water in children declines immediately following intrauterine life, reaching its nadir by somewhere around 12 years of age. And there's a shift in the fluid from the intracellular compartment to the extracellular compartment. The clinical implications of this are relatively poor adjustment to fluid deficits or volume overload or overload in neonates. In addition, body surface area is substantially larger, thus there is increased potential for insensible water losses, and you can imagine how this would be dramatically increased in an extremely premature infant whose skin barrier has not yet completely formed. So the factors then, to summarize, influencing total body water in neonates are gestational age, antenatal steroid exposure, growth restriction, kidney function, and transepidermal fluid losses. So how do we measure fluid balance or define fluid balance in these neonates, both preterm and term? Well, there's two common methodologies. We can measure weights, or we can measure the difference between what goes in the patient versus what comes out. We'll focus first on the weights, and this may be the more accurate approach than the intake and output approach, especially given the insensible losses that are not accounted for when we're strictly measuring ins and outs. There unfortunately are challenges though, including instability that may preclude measurement, and small fluctuations in weight from scale differences may make a dramatic difference. When we look at intake and output, like I said, these do not account for insensible losses. Then it is maybe imprecise measurement of urine or stool mix, and the patient may simply be too small to get a good approximation. So finally, the approach should be individualized to the patient and the illness type to obtain the most accurate assessments. So there are, as we look at quantifying positive fluid balance, we have to have some considerations. The first question is there excess fluid? And the second question is this excess fluid maldistributed? There are limited studies in children evaluating the performance of ultrasound and technologies such as bioelectrical impedance to elucidate where the fluid is located, as has been done in adults. And certainly as a rule of thumb that I like to tell the trainees is that if the baby is puffy, you can visually see it, the fluid balance is likely in excess of 20% and is likely maldistributed. If we look at this study in very low birth weight infants exposed to intravenous fluid, they performed echocardiogram and mode measurements during day 3 to 20 of life in 73 of these very low birth weight infants who were either randomized to high and low fluid regimens. The high was 172 mLs per kilo per day, and the low was 130 mLs per kilo per day, which was designed to give significantly different maintenance fluid intakes. The groups were comparable with respect to birth weight, gestational age, incidence of respiratory distress syndrome, and mean number of serial echocardiograms performed during the study period. The calorie and electrolyte intake were not controlled in this study, and echocardiographic data were compared. You can, in the study, they demonstrated that left ventricular end diastolic diameter, right ventricular end diastolic diameter, and the ratio between the left atrium and the aorta was significantly larger in the high volume fluid group. Comparison of regression coefficients showed that left ventricular end diastolic diameter tended to rise with postnatal age in the high group and fall with postnatal age in the low group. Left atrial to aortic ratio tended to fall with postnatal age. And these differences can be summarized in what the authors thought would be a reflect adaptation of the circulation to the degree of chronic volume overload in low birth weight infants. So how do these positive fluid balance associations, or how does positive fluid balance look on children? So if we look at the associations, this was a study, a meta-analysis study. There were 44 studies, 61% retrospective, a small number prospective, 7,500 children were included, and the proportion of children with fluid overload varied by case mix and definition with a range of 10 to 83%. Positive fluid balance or fluid overload was associated with increased in-hospital mortality. And for every 6% increase there was a 6% increase in odds of mortality for every 1% increase in fluid balance. And this was associated with mechanical ventilation duration greater than 48 hours, as well as acute kidney injury. But as we take this data, a closer look at this data, only a tiny proportion of the patients included in this study were neonates. Looking at this other study that evaluated a restricted versus liberal fluid intake in preterm infants, this was a Cochrane review of 5 studies, including preterm infants less than 37 weeks gestation. They demonstrated that restricted water intake was associated with increased postnatal weight loss, reduced risk of a PDA, reduced risk of NEC, and a trend towards reduced risk of BPD, intracranial hemorrhage, and death. As we look at the studies that have been done as a sub-analysis of the larger AWAKEN study, fluid balance was evaluated during the first postnatal week among preterm infants. The figure on the left is a histogram demonstrating the distribution of peak positive fluid balance stratified into gestational age, and on the y-axis is the proportion of patients who needed mechanical ventilation on day 7. You can see that there's an increase in the proportion of neonates who needed mechanical ventilation on day 7 with increasing peak fluid balance. And this was most significant in the group with gestational age less than 29 weeks. In multivariable analysis, peak fluid balance, lowest fluid balance in the first postnatal week, balance on postnatal day 7 were independently associated with mechanical ventilation on day 7. In a similar analysis, negative fluid balance on postnatal day 7 protected against the need for mechanical ventilation on day 7. These data highlight that when there is not sufficient and expected weight loss, there are implications, including increased resource utilization. The same cohort or the same sub-analysis performed among those term infants. And in the figure on the left, you show the median fluid balance. We show the median fluid balance on the y-axis by postnatal day on the x-axis, stratified by the need for mechanical ventilation in pink or not in blue. And you can see that among the patients who received mechanical ventilation on day 7, there is across the board a higher median fluid balance on every postnatal day compared to those who did not need mechanical ventilation. In the multivariable analysis, the peak fluid balance, the lowest fluid balance in the first postnatal week, and the fluid balance on postnatal day 7 and negative fluid balance at postnatal day 7 were also independently associated with need for mechanical ventilation on day 7. So how does this translate into the extremely premature infants? This was the secondary analysis of the preterm erythropoietin neuroprotection trial, which is a phase 3 placebo-controlled trial looking at erythropoietin administration in extremely premature neonates in 30 intensive care units in the United States. The analysis included 874 premature neonates born at 24 to 27 weeks gestation who were enrolled in the study. The primary outcome was mechanical ventilation on day 7, with the secondary outcomes of composite of severe BPD or death. 52% of the population needed mechanical ventilation on day 14, and the median positive fluid balance was 11% and was higher in those who needed mechanical ventilation. In the multivariable analysis, for every 10% increase in peak fluid balance, there was 103% increased odds of mechanical ventilation at day 14. But it's not just the fluid balance that affects the patient outcomes. The positive fluid balance can mask acute kidney injury diagnosis. And this again takes the patients from the PNUT trial and looks at their AKI diagnosis using serum creatinine both before and after correction for positive fluid balance. In this study, after adjusting for fluid correction, 13 neonates with AKI were reclassified as not having fluid corrected AKI, but 111 neonates previously without AKI were reclassified, as you can see in the Sankey diagram on the left, as having AKI. Therefore, fluid-corrected AKI was diagnosed in 313 neonates, which was around 33%, 10% more than without correction of fluid balance. In the study in the multivariable analysis, fluid-corrected AKI was associated with an increased odds of adverse clinical outcomes, including prolonged ventilation and severe BPD. If we look at other populations, specifically among neonates in the cardiac surgical population, this is data from the Nephron Collaborative, including just over 2,200 infants. In-hospital mortality was low, and the overall median peak fluid balance was 4.9%. In this particular study, peak percent fluid balance on postoperative day 1 and percent fluid balance, fluid overload were not associated with the primary or secondary outcomes. But for each day that the patient did not achieve negative fluid balance, there was increased resource utilization, characterized by prolonged ventilation, increased ICU length of stay, and increased hospital length of stay. Looking again at the nephron data, taking a specific subpopulation of patients with hypoplastic left heart syndrome, we characterized acute kidney injury into transient or persistent lasting more than 48 hours, which was associated with a higher mortality. But it wasn't until we took into account a cumulative fluid balance that exceeded 10% in this population, and we see a 7.8-fold higher mortality, 7 fewer respiratory support-free days out of a total of 28, and 12 fewer hospital-free days out of a total of 60. So what these data tell us is that the degree of fluid balance can certainly impact outcomes, but this construct varies based on the population being studied. This is a busy slide, and hopefully you'll be able to refer to it later, but it's just to highlight the different types and scenarios of positive fluid balance, pathologic positive fluid balance, where the fluid might be located, whether or not there's capillary leak, the oncotic pressure, the systemic pressure, and how to go about removing them. In certain scenarios, fluid removal is obviously the treatment of choice, but fluid stewardship more often becomes important. The importance can be summarized into this particular figure, where we should focus initially on resuscitation, then on to maintenance and optimization, and then focus on the deresuscitation component by removing fluid. As we look further at endpoints of fluid balance therapy and resuscitation, in adults, fluid boluses administered to postoperative patients show that a maximal effect on cardiac output occurred within 1 to 2 minutes in responders, but that effect dissipated at 10 minutes. In a separate study that evaluated the response, this response to fluid was not sustained in 30 minutes. There are limited studies of fluid bolus therapy in children, especially neonates and preterm infants, but there was a prospective observational study that demonstrated a transient increase in cardiac index within 5 minutes following a fluid bolus, but this effect, like in the adults, dissipated by 60 minutes to a lower baseline than pre-bolus. But in truth, the duration, magnitude, dissipation effect of fluid bolus therapy in children requires further study, and almost certainly varies depending on the underlying condition. Therefore, when I'm considering a fluid bolus for restoration of fluid or patient hemodynamics at the bedside, my approach is always to administer the smallest possible quantity, so 2 to 3 mLs per kilo, and stand at the bedside to observe the effect. If this doesn't result in any clinical improvement, more will not likely do so. And giving the patient, as we commonly do in the cardiac intensive care unit, 5 mLs per kilo may contribute to what ends up becoming positive pathologic fluid balance. When we have the scenario of pathologic positive fluid balance, how do we test the kidneys to identify whether or not they're capable of removing fluid? Or how do we remove the fluid when the kidneys are not capable? There's this fancy test called the furosemide stress test, which administers a 1 per kilo dose of furosemide or loop diuretic to a patient, where we quantify the urine output for the first 2 to 6 hours after the dose. It is thought, has been demonstrated, at least in adults, that a urine output greater than 1 per kilo per hour for that first 2 to 6 hours is a good effect, and the patient is likely to respond to diuretics, although this specific threshold of 1 per kilo per hour has not been borne out in pediatric studies, and certainly not studies focused on preterm and term neonates. It also is a little bit scary to consider administering a diuretic when you have an hemodynamically unstable patient. And in the adult studies that did this prospectively, they did resuscitate the patient with the volume lost to the furosemide bolus. If the patient fails to respond, so has a less than 1 per kilo per hour of urine output, then one should consider other ways to remove fluid. Among our smallest patients, how do we do that? Well, in the cardiac intensive care unit, among the neonates undergoing cardiac surgery, we often place peritoneal drains for either passive drainage or prophylactic dialysis. And this is routine for us at Cincinnati Children's Hospital Medical Center. We use 10 ml per kilo dwells, but I would say that this is not a universal approach and cannot be translated across all centers. And it really depends on the intraoperative and postoperative hemodynamics where this might be useful. Of course, when considering such an approach for an extremely premature infant or neonate, that can certainly have its challenges. In the cardiac population, we worry about communication of this peritoneal drain with the chest cavity and abdominal catastrophes. And in some of the patients cared for in the NICU, this simply isn't possible, thinking about those with gastroschisis or other abdominal issues. The last approach can either be considered as a last resort or a proactive approach. And this is the use of modified aquapheresis, or this is the approach using augmented fluid removal, mechanical fluid removal, in terms of using a machine, and requires at least larger intravenous access to be able to accomplish this. There are several tools available, machines available that this can be done. You can either use a machine, an aquapheresis machine, and place an inline filter, especially if there's metabolic disturbances. The Carpe Diem device is now approved in the United States for fluid removal and dialysis in children less than 10 kilos. And the PrismaFlex device is another one that we have available. Certainly there's the Nidus device as well. But for the PrismaFlex, at least for now, there's the HF20 filter with a small priming volume. The challenge, of course, in the premature infants is the 6-7 French catheter that's needed to be able to perform this. And oftentimes that is untenable in an extremely premature infant whose weight is less than 1.5 kilos. As we think about some of our patients who need extracorporeal organ support in the form of ECMO, standardizing fluid removal can be considered an option using either an inline filter or an inline or a parallel in-circuit dialysis machine, whatever the choice might be at your particular institution. The point of this slide is not to show you the fine details of the fluid removal algorithm, but really to highlight that it is possible to be able to augment mechanical fluid removal in conjunction with diuretic utilization to achieve a preset fluid goal in these patients. And we recently published on this work as shown, as you can scan the QR code there, among children receiving ECMO. Another approach is for augmented fluid removal can be through clinical decision support for early fluid removal. And this is done in the pediatric intensive care unit, which often accommodates children greater than the neonatal age period, but utilizes the renal angina index as well as a urinary biomarker, stratifying patients on early fluid restriction or early augmented fluid removal if they failed to respond to diuretics. And the results of this prospective study should be coming out soon. And hopefully will allow us, at least in this pediatric ICU population, to demonstrate a significant effect. Whether or not this approach would work in the neonatal ICU with a modified renal angina index or in the cardiac ICU remains to be seen. So I've talked about a lot of things today, and that leaves us with research priorities and fluid balance. We need to identify the optimal reference or anchor weight in this population. We need to study, develop, implement, and evaluate protocols for obtaining daily weights. Some centers have these, some don't. We need to evaluate the optimal method and process for adjusting anchor weight for neonates outside of the first 2 weeks of postnatal life and prolonged hospitalizations. Understand the impact of timing and trajectory of positive fluid balance on outcomes. Identify patient-specific strategies to manage this positive fluid balance in sick children that direct improved outcomes and care processes. And finally, understand the relationship between positive fluid balance and the development of pathologic fluid overload. But if this were that simple, I think we would have done it already. So if there's any engineers out there, I think if you can create us a device that we can use at the bedside that can accurately weigh, not just weigh our preterm and term infants, but also give us insight into their total body water and where this water is distributed within the body, intravascular and extravascular. I think that will hopefully lead to an early retirement for you and will change the way we care for preterm and term infants. So in summary, fluid balance and fluid overload are complex. We probably have more questions than answers. Disorders of fluid balance contribute to adverse outcomes in preterm and term neonates. Strategies exist to optimize fluid removal, but data in preterm and term neonates outside of cardiac surgery are sparse. And prospective studies that address the research priorities I just highlighted, particularly in preterm and term neonates, are needed. Thanks so much for your attention. And these are the amazing collaboratives that we have going. And none of this work would have been possible without the Neonatal Kidney Collaborative. And thank you for joining.
Excellent. Thanks, Dr. Giss, for a fantastic presentation. I guess one of the questions from us as neonatologists would be is how do we manage to provide enough nutrition, but at the same time not trying to overload these babies?
Yeah, that's a really important question. And, I think you have to look at whether or not the patient is making urine, enough urine, or not. My general approach is never to restrict nutrition. So especially in patients who perhaps have a peritoneal drain in place. But even so, I know that weight gain is extremely important for lung development and all the other things in the preterm infants. So my advice would be not to restrict nutrition until you absolutely have to, and hopefully just concentrating parenteral nutrition as much as possible will be able to get you there. Certainly, if all else fails, using one of the other approaches for fluid removal would be the way to go.
Excellent, thanks. We do have a question from Joseph Newman, who's asked, how do you assess fluid overload in extremely low birth weight infants in the first 7 days when we often don't weigh them due to the neurobundle?
That's a difficult question, mostly because I don't care for extremely low birth weight neonates in the cardiac intensive care unit. So if any of my colleagues who actually care for these children would like to interject and give their thoughts, I would much appreciate that.
That's a really good question. A lot of time we look at weight above birth weight. And we don't necessarily, so our IVH protocols are a little different, and every institution is a little different from the neuroprotective bundle, right? And so risk assessment overall, looking at, do you think this infant is at a high risk of fluid overload? Is it worth gaining the weight at the risk of breaking protocol from your IVH, right? All of these protocols are in place, but they are also, in a sense, guidelines, and we recognize that not every patient fits the protocol. So you may have deviations from each protocol, and as long as you're documenting why and why you're concerned, most places are very much okay with that. So specifically looking at that, using birth weight as your anchor weight, we will often look at cumulative intake and output. And for the most part, they're not 100% accurate in those first 7 days of life, but you can get a general sense on which direction you're headed in. And so a lot of times, instead of using a weight-based definition, we're looking at a cumulative intake-based definition.
Yeah, I'd agree. I think it's the challenge of what we all face, especially with extremely preterm babies. I think probably a lot of people would do the neurobundle very strictly at the 72-hour mark, and perhaps maybe the balance is doing a weight at the 72-hour mark to get to see where you are, combining that with your cumulative totals, your ins and outs, and then potentially weigh again in another 2 or 3 days after that. So it's trying to combine both things. You don't want to not do too little at the same time as trying to not to do much, which is definitely the balance that we all face with looking after these babies. Excellent. Were there any questions from our 6-2 crew?
I think one question that I have is, how do you approach hesitancies around like aggressively addressing your fluid overload with CRT and cardiac neonates, you know, as well as some hesitancies from heart failure or the transplant team at different times?
Yeah, I think, you know, the fluid might have gotten there quickly, but removing it at a rapid pace can certainly have its consequences. There's a lot of fluid shifts. There's this new fancy term called dialytrauma, and certainly can lead to impaired kidney recovery. And so, you know, I think taking it slow. Certainly there's some data in adults that recommends the volume per kilo per hour that should be removed. And hopefully I will be able to say the same for children in the coming year or so as we look at the data from the WeRock Collaborative, which is a CRT collaborative encompassing multiple centers of including patients across the age spectrum, of which we could specifically focus on those less than 10 kilos, which approximates some of the patients in the neonatal ICU. So I think, you know, how we do it is a great question. How should we do it? Probably slow and steady rather than fast and try to appease to the masses. And I think you're likely to have better outcomes that way. That's just my general sense of things without pediatric or neonatal data.
Excellent, great. Thanks very much, Kat. That was a fabulous talk. We really appreciate it. I'd like to then go on to our next 6-2 crew team member to introduce our next speaker.
Great. Hello, everyone. My name is Caroline Jackson. I'm a third-year nephrology fellow at Seattle Children's Hospital, and I'm very grateful for this opportunity to be a part of the NKC as a 6-2 crew intern, and I'm excited to continue to engage with this community as I begin my journey as nephrology faculty next year, with the location of that still being determined. But now I have the extreme pleasure of introducing our next speaker, Dr. Catherine Joseph. Dr. Joseph is the Associate Professor in Renal Section of Baylor College of Medicine, Texas Children's Hospital in Houston. She has clinical and research interest in neonatal nephrology, renal replacement therapies, and end-stage kidney disease, and currently serves as an Associate Program Director for the Pediatric Nephrology Fellowship Program at Baylor.
Thank you, Caroline, for that kind introduction. I haven't yet been promoted, but thank you for promoting me on Zoom. Hopefully that foretells the future. I want to share my slides and get started. I hope all of you can hear me okay. I want to thank the organizing committee and NKC for giving me this opportunity to talk. It's a hard act to follow. That was an excellent session, Kat, and hopefully I can marry some of the thoughts that you shared into what I'm about to present, although we have not discussed our talks prior. So I have the charge of talking over clinical scenarios and some decision-making and management. This session is interactive and open to technical glitches, so bear with us. But hopefully it won't be. We've come a long way in neonatal kidney replacement therapy, and I think there was an interesting publication not too long ago in pediatric nephrology describing some of the advances of technology in this arena of neonatal nephrology. So normal science would be the peritoneal dialysis that was available for all of our infants when they were deemed appropriate candidates. The extraordinary research would, in this framework that the authors present, reflect on the recent device innovation that has occurred, enabling us to use smaller devices designed for infants. The new paradigm in this article was the reference to using these smaller devices as a bridge to initiating PD, which is a more sort of tolerated long-term chronic dialysis therapy for infants. And then in this aftermath, we have a uniquely complex population with some interesting and unique morbidities who are resource intensive, even as they get closer to their second and third years of life preparing for transplant. So here is a pictorial diagram of innovation in dialysis. In the 2010 era, the work on Carpe Diem began, and finally in 2020, we have approval here in the US to use it. But before then, some devices were available to us and still are in use, and they've provided an excellent way to provide support to these infants. Aqueducts, as was mentioned earlier, can be modified for use. And NIDIS, although it was in development for a long time, has finally published their work from the UK and Ireland. So those are the QR codes for later reading. I think neonatal kidney replacement therapy is challenging. Access, fluid removal, we just heard Dr. just talk about this. What is a good goal? Anticoagulation, always a challenge, whether it's heparin, citrate, or the newer agents. Hypothermia, electrolyte issues, and communication and collaboration. I wouldn't say it's a work in progress, but there are many aspects to be continually thought about and refined as we provide care. So this is the framework on which I hope to tell you what are some common issues we may face as we initiate CKRT, the actual procedure, and then identifying some challenges with fluid removal. And if we have time, we can go over cases that also pertain to nutrition. So for this first case, we have an infant who was born at term and who developed multi-organ failure after perinatal hypoxic event and ended up with stage 3 oliguric kidney injury. The baby is ill, intubated on multiple pressors. The birth weight was 3.5 kilograms and currently weighs 4.5 kilograms. The last 24 hours has only had 5 mLs of urine. We are consulted, and after a review and examination of the patient, as well as other data, we've decided to start kidney replacement therapy. So if members who are watching can please join the poll, either by scanning the QR code or sending C Joseph 165 to this number. That will help us hopefully have some interaction to this next question. So again, the how to join the poll is up top. You can do it by text or by the QR code. And hopefully we can answer the question. As you get ready to initiate CKRT, who is typically at the bedside? Is it the nursing staff and a medical provider, either from ICU or neonatology or nephrology? Or is it all members and all stakeholders of the major teams providing care? Or is it just depends on the structure of the program. Is it just nursing that are always there? And I realize we're coming from a framework of multiple organizations across multiple countries. So this is definitely dependent upon the practice of the institution. So I am getting responses, and I'll probably give another 10 seconds before we close it out. And just because of the nature of multiple technologies with this talk, I will just verbally tell you what where the answers lay. So I think the majority, about 65%, 65 to 70% vote for B. That's all stakeholders at the bedside to provide this therapy and care. And the rest of the responses are tied up between A and C. So moving on, the start is a procedure. And so again, I recognize the limitation of the slide in that, not everywhere does it the same way, but I'm just sharing some insights as to potentially what each team member brings to that procedure to provide the best outcome. So our nurses set up the device, verify the bags, the prescription, talk to pharmacy, they double check the access that our intensive care or surgical colleagues have placed. They will verify the dialysis anticoagulation prescription and how it's entered into the circuit or to the patient. the physicians at the bedside or the advanced practice providers outline the blood pressure goals and plans for resuscitation that they agree on. The bedside nurse can confirm fluid rates and patient stability and resuscitation. And the procedure to trace lines and make sure everything is connected after we're initiated is also a key portion of this. And I think just a reminder, you're back in the poll again for the next question, which would be 5 minutes after initiation in this infant in whom we are using citrate anticoagulation. The baby, as a reminder, has anasarca, is on 2 pressors. Your blood pressure readings have trended down significantly, accompanied with bradycardia. My question is, what do members of the audience want to do next? We'll just give it another 10 seconds, if that's okay. All right, so I think moving on, thank you for participating. Most of the folks have responded towards the use of calcium, but there is a fair amount of, that's about 55% of the audience. The remaining are split between all of the remaining options, but perhaps at this time, the less popular one is checking a temperature on the baby and warming the baby. So I think our lead here is calcium. So as we initiate, I think as a team, as a group of people who are invested in this infant, we're all going to be prepared for the common side effects. That's hemodynamic instability, tachycardia and hypotension being the big players. Hypothermia is important. We have a warmer on the machines, especially with the larger machines that are adapted for infant use, like Prisma. They may not be sufficient. And of course, our neonatology colleagues do an excellent job of continually regulating and monitoring temperature. So this change is possible and can lead to hemodynamic changes. So it's important to monitor for that. Before we connect the patient, if there are calcium abnormalities or even a low albumin from the morning rounds, or if there are medications for hypertension, imagine you have a patient with recessive polycystic kidney disease who's been hypertensive and edematous for ages now and probably on 1 or more drugs. We have to keep that in mind before we connect, because that may be the patient who, unlike the patient in this case, who actually may need to get that drug stopped or weaned in preparation for the start. That first hour is important for monitoring. You could say it's true for all duration of the treatment, but especially that first hour. And remember, we who prescribe the therapy have the control over fluid removal, so that doesn't need to be started right away, especially if it's a tricky start, the patient's already unstable. You could consider delaying your goals and maintaining an even balance or not turning on fluid removal for a little bit. Why is this important? This has been studied in adults, but even in children, there was a study done from our center looking at what happens during hemodynamic, what the changes during a CKRT start. Hypotension is common. In this particular study, we had 70 infants, about a third of them were under 2 years of age, but only 2 of them were, under 2 months of age. So not necessarily applicable to the neonates, but this does sort of is similar data that we got even from adult studies and other children, pediatric studies as well. So the authors, they measured heart rate and blood pressure every minute for the first hour after connecting the device. And hypertension and tachycardia are pretty common. And fluid removal also plays a role, as well as the size of the access. So I think there's data out there. It's not necessarily designed for neonates, but it's something for us that gives us food for thought. And I think in this case, yes, I've put a green tick mark next to calcium, but I think the reality, as we may face in our institutions, we have to keep in mind what's easiest for me to get to. if I'm prepared with everything and I have all options, I don't have a calcium immediately, a lab value to guide me, and I'm not sure if the calcium is going to take 15 minutes to come from the NICU pharmacist after verification, then use what you have. You might, some of us have responded by using the pressors or giving a bolus because that's immediately available. That's appropriate. I think the point is we're trying to resuscitate the patient. Even though, yes, fluid might, to Dr. Gist's point from previous talk, you would try to do a small bolus and then try to add a bigger amount as needed, so you don't worsen the fluid balance. But yes, if it's possible that here calcium is playing a role just because of the dynamics of citrate. And I haven't told you whether this patient underwent a blood prime or not. So that's another factor that can add to the hypocalcemic risk. So in summary from this case, I hope that you realize that hemodynamic instability is common. We do need to study this better. We need to respond to it though. And we need to prepare and communicate ahead of the start when it occurs. So that being said, I'll switch gears to another question. The next day during rounds, what fluid removal goal do you want to set? And that's for the 24-hour window. You are given on rounds based on discussion with all members of the team. The total intake is 300 mLs. And this just happens to be one of those days, like everything is going as planned. So there is no unexpected transfusions, nothing out of bounds. All the meds, the flushes, everything's been counted. So 300 is your final value. Just a reminder, the weight is dry or reference weight is 3.5 kilos, and the current weight is 4.5, the baby's anuric. Let me actually just quickly activate that question. I'm sorry. Okay, hopefully. Okay, we'll give it maybe just another few seconds. Okay, so I have a majority, about 85% responding to option A, 400 mLs, and the remainder of the audience have voted for C, 300 mLs. So yeah, I think before I get into the answers, we just have to remember, we've just heard a fantastic summary of when we could use a device for ultrafiltration. And if we get to that point, I want us to remember that that's something that we can do by generating pressure across the membrane to move plasma water across the blood compartment into the effluent compartment. This process is independent of clearance, but oftentimes there are changes with hemofiltration. Example, for convective changes, we can have solute movement as well. It's important to remember now that with these smaller machines, we no longer face the difficulties of inaccuracies of ultrafiltration as much as we did with the bigger machines. So the error rates have gone down significantly. For example, with Carpe Diem, it's about 30 grams for 24 hours, versus that was the rate of error probably on an hourly basis with a bigger machine or more. Nidus out of Newcastle and the UK has an error rate that's much, much less than that. So their fluid accuracy studies that have come out in the smaller study right now have really been, less than 10 mLs, I think. So I think that is really helpful, that with the advent, what we dial in is, is what we get with the smaller devices for the most part. I think this has kind of been touched upon. I want to remove fluid because we heard a lot about why fluid balance, a positive fluid balance, and how it correlates to outcomes and mortality. But removing it too quickly or not quickly enough, is that even important? I think we know from the dialysis population for the children who are on chronic hemodialysis, and this data has been shown over and over again in adults as well, that just the routine process of doing hemodialysis in a child keeping the ultrafiltration goals within targets for that procedure, even though it doesn't really overtly cause cerebral hypoxia, it can worsen strain. So there are markers that have been looked at in outpatient units. And I think some of the important points Dr. Gist was trying to drive home is like that end organ damage. And more importantly, for someone in the critically ill situation in the ICU who has a potential chance of recovery, how much are we impeding their end organ perfusion to the kidney? We look forward, of course, as a group and as a community to the work that the WeRock Consortium is going to publish shortly in this regard. Until then, we have some adult data as well, as referenced. Here is a graph from a review from Rajiv Murugan that looks at mortality and ultrafiltration rate for these critically ill adults. This data comes from large observational studies in adults, looking at the detriment of removing fluid too slow and then taking it off too fast. And there are some thresholds that are described between 1 and 1.75 mLs per kilo per hour for adults. We don't exactly know what they are for children and recognize that these are not laterally transferable, but it does open an arena for us to think about carefully, especially if we go too quickly. This graph, again, demonstrating for our children why end organ perfusion to other organs over time, it does matter, especially if we think about the population of kids who are trying to be bridged from one dialytic therapy to the next because they have end-stage kidney disease as newborns. I think all the more reason to be very mindful of what we're doing and how to even look at that. So I think I will say that I just applied, a general adult principle and went with 400 mLs. But for those of you who answered 300, that I think is also very valid because I don't think we've shared enough information on this platform today to make perhaps, informed decision fully. So I think being conservative is the key. So 300 or 400 are both acceptable answers, I think. Also, we haven't gone over ins and outs, et cetera, but I kind of try to tell you it was a fixed number, but not to exceed, and not to be too aggressive. And even as you prescribe a dose of fluid removal, what happens in the next 2, 6, 8 hours matters. So if that infant doesn't tolerate because of X, Y, or C, sepsis, hypoalbuminemia, things need to be reconsidered and reconfigured rather than just wait till the next day. So I think we don't know enough, and I think I won't harp on this much more, but we do need to study it more. And I think our community here today hopefully can come together in the future to do this in a very structured fashion. I am not sure if I have time for another case. But okay, I think I'll go forward. Let's see if we can, we have one last case. 4 days after kidney replacement therapy has been initiated, you review labs on rounds and you see that the phosphate is 2, and your baby is on TPN and not on enteral feeds. What is, in your opinion, a good step to address this hypophosphatemia? The infant is planned to remain on kidney replacement therapy, both the day of the rounding and the next day. You can just assume that. And the rest of the labs are reasonably within your target goals. I think the majority agree that we would increase the phosphate in the TPN. And so that is the only answer I have. I just want to summarize, since we may be a little bit behind on time, that AKI does affect metabolism. We know that there are a lot of derangements that occur. Inflammation plays a role. Nutrition matters, as was brought up by the audience question from the first session. Hypophosphatemia is really common. whenever possible, just given the rate of loss, it's best to optimize it in TPN or dialysate bags, and making sure we look at other medications. In this context, I just want to bring up two other things. Protein losses are present and significant on kidney replacement therapies, as evidenced by both adult and pediatric studies. And we should definitely try to meet their needs and exceed the prescribed need when they're on continuous replacement therapies to offset the losses. We should try not to restrict protein, as was already mentioned in the Q&A in the last session, and instead use kidney replacement therapy as a vehicle to deliver adequate nutrition. One last comment about carnitine. It's really well studied, and it's lost. Neonates, it's lost on kidney replacement therapy owing to the nature of the therapy. It is something that is neonates are at risk for at baseline, and when you combine that risk factor with the use of KRT, I think supplementation is critical. Its deficiency can lead to issues both with cardiac performance and anemia, amongst other things that we fully don't understand yet. So I think in conclusion, I would say that there are many aspects of nutrition that are not well studied. The reference weight or a dry weight is something that needs to be established and then reassessed frequently. And correction of electrolyte issues, providing protein and carnitine are really important. I think one thing we have to acknowledge is that neonatology providers grow babies really, really well. And I think when we have this subset of those babies who are affected by kidney disease, we can do a better job of figuring out how to do it, how to monitor it, and how to figure out the long-term outcomes of that. So with that, I would like to thank all of you for your attention. Please scan the QR code so we can do better for our next round of educational sessions. Thank you.
Thank you so much, Dr. Joseph. Maybe while we're waiting for people to put questions in the chat, I had one question. In reference to your second case, when we're thinking about end organ damage and ischemic injury to other organs, are there any useful lab parameters or other monitoring tools that you tend to use to see if that's happening while a patient is on renal replacement therapy, which can sometimes change different values in labs? What do you use?
So great question. Are you referring to like how I would measure changes in cardiac function or perfusion to the brain? Okay. I don't necessarily I have my bedside tools, right? I have my changes in vital signs. And if, if I have a patient who has a need for an echo clinically, that might be ordered, etc. But in real time, do I have something? The short answer is I don't have great tools. More importantly, in babies, I don't think we know exactly what they are and how they work. So I invite this question for also the amazing panel that is on with me to help answer.
Yeah, I'll just add that I don't think there's one specific tool that you're going to use. So if there's hemodynamic issues, you're going to use a compilation of the hemodynamic data and perhaps blood gas assessment, although that can be somewhat skewed when you're fixing the metabolic derangement. But certainly if the hemodynamic assessment looks like there's low cardiac output, then you don't always need an echo to verify that. You can go and examine the patient. That oftentimes is helpful. But if all else fails, certainly there can be an effusion that develops if there's an error in pulse pressure. So I would just try to piece all together all the hemodynamic data together, and non-invasive monitoring like near-infrared spectroscopy is oftentimes very helpful. We use it on every patient in the cardiac ICU.
One of the questions that I had for you, Dr. Joseph, is what do you do about measuring albumin, and do you use albumin when you are doing CRRT to try and help with intravascular volumes?
I think for, in pediatric patients in general, we do tend to look at that and try to correct it. I think for babies, it's a slightly different story in that, the limits of albumin being low and severely low are different based on their gestational age. And even the norms for that are not necessarily perfectly defined. I think it's important to consider it as a tool, but I'm not certain we can be as prescriptive as we are for the older kids. And again, if anyone has any other thoughts, please chime in.
I'll add that I agree with you, Catherine, on that. I think everybody practices a little bit differently, but I don't know that there's any great evidence out there to guide that practice. I'm a bigger advocate of checking a urine protein, which we don't know normative values on, but then I feel more comfortable replacing it, showing that they're losing it from their kidneys. But some of my colleagues get very anxious about giving albumin, and the fluid shifts that come with it.
Yeah, in the recent survey that we did looking at neonatologist practices, about a third said I never use albumin. About a third says, yeah, sometimes. And about a third said, yeah, I'm comfortable. I do it all the time. So it's interesting. There's a lot of differences in practice across neonatologists.
Well, and 5% is different than 25%, which is slightly different than putting it in the TPN. And
yeah,
very interesting.
Yeah, I think for me, it's a pragmatic thing, giving one dose and seeing what happens hemodynamically, I think is sometimes very helpful, and especially in kids that you're trying to take fluid off, but you can't because you're sensing they're intravascularly depleted, and perhaps it's because of the low oncotic pressure.
Excellent. Great. Well, thank you very much, Dr. Joseph, for a fabulous talk and giving some wonderful case presentations for us to think about. I'll pass on to our next 6-2 crew member to introduce our third speaker.
All right. Hello, everyone. My name is Dale Bondurov, and I'm also one of the members of the 6-2 crew. I'm a third-year NICU fellow at Rainbow Babies and Children's, and I'm honored to be part of this group. And I'm currently still actively looking for a job next year. I'm here to introduce Dr. Kara Slagle. She's an associate professor and co-director of the Center for Acute Care Nephrology at Cincinnati Children's. Her primary research focus is on urine biomarkers and fluid balance in non-cardiac surgical strategies to improve outcomes in neonates with AKI. Without further ado, Dr. Kara Slagle.
Thank you so much for that kind introduction. So I've titled this talk From Diapers to Diagnostics, How Urinary Biomarkers Can Be Useful in the NICU. From disclosures, I should say that ChatGPT wrote my title. I'm not that creative at baseline. And I couldn't find that title had been stolen from anyone, so I went with it, but I apologize if someone else has used that title before and I stole it from you. I'm also a consultant for Medtronic and AM Pharma, but they're not relevant to the contents of this talk. The objectives that we'll cover, hopefully, is to understand the relevance and clinical significance of urinary biomarkers to detect neonatal AKI, to explore clinical applications and current research on urinary biomarkers to detect AKI, and then to discuss challenges in future research directions of urinary biomarkers. So what are the problems with our current definition? Well, we know that urine output and serum creatinine are indications of functional kidney injury. And our goal is to prevent not only the acute problems of morbidity and mortality, but as well as the progression to chronic kidney disease. And the way that I think about this is that when you have a healthy kidney, right, and then you develop AKI, If I'm explaining it to my fellows, I often tell them, or residents for that matter, just because you lose function in your arm doesn't necessarily mean that you have fully injured your arm. Maybe you had an injury to your neck, and so now you can no longer use that arm. And so what that looks like from a consequence, if we truly think of CKD as renal scarring, may be very different. And so interpreting AKI and progression is going to need a lot of work in the future. So functional loss does not equal direct injury. As for daily serum creatinine for screening, though, it is our standard of care, and you do have to do it. So if you look at the AWAKEN cohort, AKI correlated with the number of times serum creatinine was checked. It's required in Baby Ninja, too. Baby Ninja, which looks at nephrotoxic medication and preventing AKI through hopefully reducing nephrotoxic medication use during that high exposure period, you need to keep checking to know if you're having AKI. So they ask for daily blood screening during times of that high exposure. But all of that comes at a cost, right? Not just a financial cost, but a cost to the infant and a cost specifically related to blood. So let's think about this with a case study. We have a 28-week infant with IUGR. There's intermittent absent in diastolic flow since roughly 18 weeks and ongoing poor growth. They're well appearing though after delivery on CPAP, and you have normal electrolytes at 24 hours. We know IUGR and extreme prematurity are AKI risk factors. So we should screen daily for AKI, right? What cost does that come at though? Let's think about it. The blood volume of a preterm infant, depending on how early you're going, is somewhere between 80 to 90 mLs per kilo. But for this infant, I'd probably go with the 90. They're roughly 500 grams because they're IUGR. So their total blood volume is only about 45 mLs. Our max daily lab draw for most policies at many institutions is no more than 4 mLs per kilo per day, which is only 2 mLs. So the goal is we've got a problem and now we need to find a solution. So can we use the urine? Well, it's great. It's discarded, right? It's going to go in the trash otherwise. We could use a bladder catheter if it's in place. We could also potentially use cotton balls if we're really struggling, or a bagged urine. Only consequence is they must be peeing. And honestly, if you're not, you probably already have AKI. There's different biomarkers out there. These are just some of the examples, but there's many. So NGAL, which is probably one of the most frequently studied in neonates, IL-18, Chem1, osteopoietin, beta-2 macroglobulin are some of the ones you're going to see. Those are mainly your tubular markers. You have a new one on the horizon, olfactamine 4, which is a loop of Henle marker. You have your nephro check, which is more well-known in the adult population, but TIMP2 and an insulin-like growth factor, which are expressed in the tubules, but are also indicators of G1 cell cycle arrest. And then you have cystatin C, which, depending on whether you're checking it in the serum or in the urine, could be a tubular biomarker or a functional biomarker. Urine NGAL is the one I tend to talk about and what we'll focus on today, and this is a picture of it. Primarily because it's the most well-studied. It's expressed in the renal tubules, like that picture that I just showed you, and it increases within 2 hours of a renal insult. So in theory, it will increase before serum creatinine. It is associated with increased morbidity and mortality, and urine NGAL is clinically available by the urine NGAL test from Bioporto Diagnostics. So what about urine NGAL and neonatal AKI? Well, David, who's on this call, has studied it in very low birth weight infants. Bojan studied it in cardiac surgery. It's actually very well studied in cardiac surgery and associated with morbidity and mortality. Janssen looked at it in gentamicin exposure and found an association. And then we looked at it here following non-cardiac surgery, which it had a very nice AUC of 0.81 and predicted AKI if you took it at about sometime between 24 to 48 hours. When it comes to gestational age, though, we do have to consider that our neonates aren't just small kids. And so hopefully in the next year, we'll have normative values for children, but neonates are a little different. And so Dr. Askenazi looked at this and grouped them by those less than 26 weeks, 26 to 28 weeks, 28 to 30 weeks, and 30 to 36 weeks, as you can see here. And NGAL in particular has an inverse relationship with gestational age, but also Chem1, cystatin C, and beta-2 macroglobulin. So you do have to think about this as you're trying to interpret some of these values. I'm hopeful that he will publish the data, hint, hint, about what these look like. I have seen it from a poster presentation that they did related to how these values change over time, because there's also very little known in that area. Just because you're born at 26 weeks, what does your NGAL look like at 28 weeks then? What about as you get closer to term? Does it normalize? Does it not? And so once we're able to read that paper, I can't wait to include that in future talks. But it is something to consider as you're taking this and trying to get it clinically and understand how to use this value. Now, I could probably spend another 15 minutes today arguing, is this really, he forced AKI into this model so that it's not just that 26 weekers have more AKI and thus their NGAL values are higher, but is there a component of subclinical AKI? And I offer anyone who's on this call who wants a good project in the future to try and study that. So let's go back to our patient, right? 28-week infant, IUGR, we should be screening daily for AKI, right? Just think to yourself right now, because I'm not going to do a poll since there is a little bit of a delay and lag, but how many of you would actually screen daily for this infant, especially if they're on CPAP and they had normal electrolytes at 24 hours? Many of us are checking these electrolytes, anticipating that this infant is probably going to be on TPN and a slow feeding protocol, but there may be a day break in there where you're like, oh, I'd really like to not take blood from this infant for the next 2 days. Can we get labs on Thursday or Friday and not check them again till Monday? Again, we're not getting daily AKI labs, though we may not catch AKI. So what about AKI screening? Can we use NGAL or another urine biomarker for AKI screening? Let's just keep going with this infant. Let's say on day of life 5, they have worsening metabolic acidosis, hypothermia. Oh no, they have a SIP and a drain is placed. Oh, their swab comes back for those of you who swab for MRSA on a screening assessment. And so you're required to use VANC. Maybe you're a center that uses vancomycin. Maybe you're a center that uses vancomycin flagyl like we do here. And it's initiated, and so you're going to treat for at least 10 days. For us at our center, because we're a Baby Ninja collaborative site, they'd qualify. And so would you get daily labs? And the next 72 hours, 10 mL is taken for repeat blood cultures, which is 22% of this infant's blood volume. So most likely you're talking about transfusing this infant if you haven't already. The electrolytes then stabilize and look pretty good. So would you continue to do daily screening with serum creatinine if you didn't need electrolytes? Or could you use an alternate solution? So Baby Ninja, for those of you who aren't familiar with it, NINJA stands for nephrotoxic injury negated by just-in-time action. It was initially started as a collaborative here in the hospitalist group for peds, and then expanded to UAB in their NICU as a quality improvement collaborative. It mainly is focused on screening for nephrotoxic medication AKI with the goal to reduce nephrotoxic medication use and exposure leading to AKI prevention. But like we talked about, it requires that daily serum creatinine monitoring during periods of exposure. So we're really lucky at our institution to have NGAL available clinically. And our group said, hey, we've looked at this in non-cardiac surgical patients, and we've seen that it can predict AKI. Can we use it as screening so that we don't have to draw daily labs, especially on maybe some of our infants who didn't have a SIP and are more stable, but need VANC for a much longer course, or other gentamicin for a longer course. And so we created an alternative pathway or a complementary pathway, depending on what you want to call it. And our Baby Ninja is primarily driven by our pharmacists here. So it's pharmacist-led. We have a pharmacist on our rounds every day, and they have a list that's prompted for Baby Ninja. And so that status is discussed daily on rounds. We talk about any potential medication changes, which often there are not. We've tried to restrict our medication or antibiotic exposure as much as possible because that's the most common one I feel like that we see. And then we talk about whether or not they have AKI. Do we have labs that show that AKI criteria are already met? Or is there a rising serum creatinine that we're worried this infant is developing AKI? And if that answer is yes, which sometimes it is, then we say, well, we know we need serum creatinine because that's the gold standard to diagnose AKI. And so they are down the daily serum creatinine pathway. And some of our providers will then go on to trend NGALs with it, which we'll talk about when we come to diagnostics. But if the answer is no, then we ask ourselves, we want to be mindful stewards of cost. Is serum creatinine being obtained for other indications the next day? If the answer is yes, okay, well, then we'll just go with the serum creatinine and we'll revisit this whole pathway the next day. But if the answer is no, this is where NGAL gives us an opportunity. And so we order NGAL for that afternoon or that evening, and the APPs look at it. And our threshold is 150. While we recognize we're going to get some of those lower gestational age with normative elevated values, we decided that we wanted to capture much, much more and have a very sensitive marker. And so if the answer is no, basically their NGAL is less than 150, then we do it all again the next day. But if their NGAL is greater than or equal to 150, we get a little concerned, and that's when we flip over to the daily serum creatinine pathway. So how has this impacted us? Well, we were a Baby Ninja site before we clearly switched, and we were well established. And so we had an 81% screening compliance rate with daily serum creatinine. We had previously looked at transfusions related to this and shown that there wasn't an increase in transfusions with moving from an every 3-day serum lab to a daily lab. But we still had a lot of providers who had a lot of angst related to taking daily serum creatinine when they felt the risk for AKI was low. So when we initiated this, we continued to track it. And at the start of NGAL screening, you can see that we have a shift in our metrics, and we increased our screening compliance up to 92%. And this isn't published yet, but hopefully maybe if somebody is reviewing this paper currently, that it will be available in the near future. Additionally, we saw that 35% of all overall screening following the implementation occurred by NGAL. And if you took the patients that had to either stay on the daily AKI pathway or serum creatinine pathway, because they had AKI, or they had flipped because of a NGAL that was elevated, if you excluded all of those patients and just took the days that they had the option to get NGAL, providers chose NGAL 70% of the time. And so this kind of fits with the current consensus recommendations that were recently published, right? We need tools that look at AKI risk assessment and try and put this heterogeneous population of, in this picture is children, but we also need them in neonates as well, and put those in a higher category for who's really at risk for AKI versus standard risk so that we can do kidney focused care in the future. And so hopefully that's a future direction that we'll head in. Well, we don't necessarily start with healthy kidneys. We started at-risk kidneys. And we've covered a little bit about how a biomarker can be useful in that situation. But what about with AKI? Well, if you have this patient, let's just say you're given this patient and someone comes up to you and says, the patient looks gray, but you're only given a pH of 7.1. It makes it very difficult to know what the next steps are, right? Because a pH of 7.1 and a PCO2 of 105 is very different than a pH of 7.1 and a PCO2 of 35 and a base deficit of -14. And so hopefully in the future, we'll get to something that looks more like this, where maybe AKI equals what looks like a gas. You have an NGAL, Chem1, maybe you look at your albumin, you do the FST, which Kat mentioned earlier, you get your serum creatinine, you calculate your % fluid overload, and you look at your urine output. And maybe based off of what this tells you, you change your medications, you adjust your fluids, or you head towards renal replacement therapy, right? It's all about expanding the toolbox. Instead of having this dinky little toolbox, we want to move to something that's nice and fancy and have a lot more tools and a lot more space for them. So let's move on to a second case, particularly with AKI diagnosis and how this may be helpful or change your practice. So this is an infant I actually had recently. He was a 37-week male infant with a mild to moderate congenital diaphragmatic hernia. No one could decide which category they wanted to put him in because his liver was down and his O/E ratio was right on 34%. He had a normal fetal echo and no other anomalies on fetal MRI. He was delivered via C-section. He had meconium at birth and immediately intubated in a replogal place per standard of care. His APGARs were 6 and 4 at 1 and 5 minutes, respectively. He underwent an open repair on day of life 1 and extubated on day of life 4 to CPAP. On day of life 5, he became persistently febrile through Tylenol and scared the living daylights out of me, but continued to be well appearing other than a little bit of increased tachypnea, and a workup was initiated, and he was initiated on AMP and gentamicin, and he had no growth on his blood culture, and so they were stopped at 36 hours following his blood culture. On day of life 7, he was noted to have very excessive weight gain and increased tachypnea again, and it was thought to be fluid related, so he received 1 mg per kg of IV furosemide. On day of life 7, he was also fortified to 22 kcal per our protocol. On day of life 9, his creatinine was noted to increase from 0.35 to 0.7. And this is a graph of his creatinine. So here's where his septic workup was performed. He completed his 36 hours of antibiotics, honestly, between these two lines. We gave him Lasix and fortified him. And this is what it did following day of life 7 to day of life 9, when I really started to get anxious and then continue. So looking at these labs in a tabular format, day of life 11 was 1.25. And at first I thought, okay, I can take that this is a little bit of a diuresis. Serum creatinine is a concentration. He's slowly switching to PO formula too and taking a little bit less, so his total fluids are going down. But I said, let's just get an NGAL. So we got an NGAL, and his first NGAL was 65. And I felt a little bit reassured, but I said, okay, let's trend it over time. On day of life 12, it was less than 50. On day of life 13, it was less than 50. On day of life 14, it was still less than 50. And on day of life 15, it was less than 50. So it made me feel much better. I did want to give him a little bit extra fluid, but at that point he had lost his IV and he was taking decent volumes. And so we just continued to watch it since it started to trend down. Let's take a different scenario though. How would this have changed if his NGAL would have been 750 on day of life 11? And then on day of life 12, if it would have risen to 1200. Maybe on day of life 13, then it drops to 800, and then 425, and then 375. Which is not unusual for other patients that I've seen. Would you treat these two patients differently, the one with 65 and then progress to less than 50 versus the one with an NGAL of 750 that rose and then fall? Would you treat this patient differently, specifically based off the fact that on day of life 13, their NGAL is starting to get better? And if your answer is yes in any of those, or you're thinking about it, and you're thinking at least it helps inform your decision and it's urine, so it's discarded, then maybe NGAL is something that you could use clinically too. So we've gone from the at-risk to the AKI, but of course, most of us who are neonatologists and are very interested in long-term follow-up outcomes also want to know about the risk for progression to CKD, or maybe the risk for progression to look like this if you're an FST patient. And so this is where dynamic AKI phenotyping can come in. And so this is another lovely figure from that same paper, which kind of discusses the fact that there are very different dynamic AKI phenotypes. And you'll see in this nice little yellow box up here that biomarkers potentially can really help us play a role for ongoing assessment to get these different AKI phenotypes to really look at prognostic implications and therapeutic implications in the future. Because right now our populations are just very heterogeneous. We have the arm injury, we have the neck injury, and we're trying to really understand long-term outcomes. And maybe that's why in adult studies, at least, it hasn't continued to show success. So current research and future directions, there's a plethora. Can we incorporate urine biomarkers into clinical practice? And how do we do that? How does it change our clinical practice? What are patient-centered outcomes and comparative effectiveness studies that we can do? Can we use something like the RAI or the renal angina index in the PICU instead of me getting renal angina when I see that serum creatinine? What about subclinical AKI? Are normative values truly normative, or is it just underlying subclinical injury? And does NGAL actually correlate better to CKD, maybe than a rise in serum creatinine? Maybe these subclinical patients we actually need to follow out long-term. Olfactamine 4, there are other biomarkers than just the one I talked about today. So understanding loop diuretic responsiveness, which many out there are trying to do right now. And is there implications with going on to neonatal dialysis? Can it predict who's going to be responsive to loop diuretics? And some of these from the priorities for the next step come from that 26th ad key related to pediatric kidney health, especially as it applies to neonates. Epidemiology, we need more data, we need more knowledge, we need biomarker association to long-term outcomes. Diagnostics, this integration of concurrent diagnostics and adding to the definition. How do biomarkers in preterm infants change as postmenstrual age changes? When it comes to treatment strategies, patient-centered comparative effectiveness research, do biomarkers change the treatment strategies? Do they impact the timing of dialysis initiation? And then, of course, always educational, government, community partnerships, and cross-discipline healthcare training. There are multiple collaboratives out there, which you've heard already. These are just a few, and I'm sure many of us who are interested in biomarkers within these collaboratives would love to continue to do studies. So please don't hesitate to reach out to anyone. We're always looking for new partners and interested minds. Thank you very much. Oh, I guess I can share again to leave my post-survey link up.
Thanks, Cara, for a fabulous talk. How did you get your team there to accept using urinary NGAL as a clinical marker?
That is a great question. Interestingly, so when we use it for Baby Ninja, it was actually primarily driven by others, not me. And I think some of that comes from ongoing education. And when you hear it enough, people start to ask questions like, can we really do this with risk assessment? And so after a lot of research studies and them hearing me talk and beating on their doors and saying, hey, look at this cool tool that we have. And some of it driven by my nephrology colleagues too, who with babies that they were following for AKI or other renal anomalies, continuing to get those daily NGALs with the serum creatinines and our providers becoming much more comfortable with seeing those values was what really drove a lot of the clinical change.
And when you sort of talk about the costing of it in comparison to a creatinine, what are we looking at as far as being able to compare the costs for the two different tests?
Sure. So every institution's a little different, and some of that also depends on the cost the patient sees versus the cost of the healthcare system. But for us, when I ran the numbers here, a serum creatinine costs about $56. If you're getting a BMP, because half the time when I ask for a serum creatinine, even if I only want a serum creatinine, I end up with a full set of electrolytes, and that's around 100 to 120 US dollars. And then sometimes if somebody says, oh, I want a TPM profile because you're going to check, then you're looking at closer to 150 US dollars. For us, for urine NGAL, it runs about $20 to $30, so it's much cheaper than even a serum creatinine. I do know that is somewhat driven by the lab. And so at our institution, just because it's that price doesn't necessarily mean at others' institution it is that price. And so really understanding what your lab cost is very important when it comes to talking about financial cost. But then I also think we have to consider the burden of the blood, right? And the cost of, do you have to poke the baby? Is it a heel stick, or can you get urine as well, which are some costs that we don't always necessarily consider because many times we don't have the option. It's blood only.
Great. Is there any other questions from our panel and our 6-2?
Allison, I just wanted to comment and to Cara that we have published data from the PEANUT trial on urine biomarkers in pediatric research in 2011. And importantly, those are patients who are less than 1,000, well, less than 28 weeks. And we took out the AKI patients so that we could look at the normative value in non-AKI patients. So I encourage you to take a look at that. And then we also published in that same cohort on neonates who had AKI in the first week, and we just got accepted a manuscript looking at values at around 34 weeks, biomarkers and their ability to potentially predict 2-year outcomes.
Thank you. I'll definitely take a peek at those.
Kara, I have one quick question, unless there's online people, I don't want to take away from theirs.
No one online at the moment. Thanks, Kat.
Okay, yeah, Kara, we're lucky to have the ability to test both NGAL and creatinine at Cincinnati Children's, but if you were in a resource limited environment and you had to choose one, what would it be and why?
Ooh, good question. In a resource limited setting, I think it depends on what resources are limited. If it's also nursing care and lab draws and those kinds of things, urine's easy and it's low cost if you can get it there. And so then I would lean towards that. However, if you're in a setting where blood is easy to get and you're needing to collect it for other reasons, then it may be that serum creatinine is the route to go, because that is continued to be our gold standard definition for now until we incorporate some sort of urine biomarker into the definition of AKI. And then I think that may change this discussion.
Thanks.
Great question.
Have we got any questions from our 6-2 crew?
Yes, hi, sorry. I do have a question. My first question was already asked about the cost. With that said, NGAL seems to be a really promising biomarker. How do I get my institution to use it?
So the first question is, do you have it clinically available? Because not every institution does. And if you don't, we can advocate as neonatologists and we can help. Sometimes it has to do, every lab's a little bit different. And so it is not currently in the US FDA approved yet. And so there is some holdup at some institutions from that specific piece. But I think the more that we can show that we're going to use it and how we would use it and how it might change our practice is the key critical piece that's missing there, right? Because we practice as neonatologists off-label for most things. And so I even go over to the adult hospital because that's where some of our deliveries are. And I'm like, hey, you guys should use this in your ED. Can you get it? Because we'll also use it. Because we can only do this with Baby Ninja here at Cincinnati Children's, because otherwise it's a send out at some of our delivery hospitals where we really see our extremely low birth weight infants and some of the other infants that would really benefit from this, because then it becomes a send out lab. And so then the return is much longer. So you'll have to think about each of those pieces and how they can impact and whether you have it clinically available. But again, I think the more that you talk about it, the more that you educate your providers, and if you can get nephrology to help you get neonatology buy-in and general peds buy-in, then it would be great.
We are working on getting it rolled out at our institution, and I think we had a very special guest speaker for Grand Rounds. Some of you may know Dr. Goldstein, who came and spoke eloquently and helped really give the context for it. But I think the other thing we're working on is our patient selection guidelines. So being really clear about which patients we're going to send it on and which patients we won't, so that it's not just kind of open willy-nilly to everyone who wants to send it on any random patient. We want to make sure we're using it in a way that does guide our practice.
Cara, I was just wondering what your thoughts are as to how we change people over thinking that creatinine is our best marker for acute kidney injury. It always reminds me of a slide and a talk that Pat Brophy used to give, and demonstrated that with for patients having myocardial infarctions, we've gone from having CK to then troponin, but we continue just to look at creatinine for our patients with acute kidney injury. Do you think we'll ever get there to having people think that a urinary biomarker is perhaps the better indicator of an acute kidney injury rather than creatinine.
I do think we'll get there. Honestly, I'm going to throw my group a little bit under the bus here, but I never thought I'd convince them. So the fact that they drove a lot of the change for the Baby Ninja project really helped seal that, okay, we can do this. It just takes exposure and time. And I think everybody learns a little bit differently, right? And so it's more of a comfort thing. So I think we can drive it at the leadership level by adding it to the definition and really setting the standard for that. And then I think once people start to use it in conjunction and really see that, oh, look, NGAL falls before you see the serum creatinine fall, and it's going to change clinical practice. I'm not just getting another lab to get another lab. And I think that's where we'll really start to get additional buy-in.
Excellent. Thank you very much, Cara, for a great talk. I think we're all sort of hopefully going to encourage our groups to get NGAL as part of our screening process. I know that Sick Kids in Toronto was also going to have a screening and management protocol for acute kidney injury in neonates. So I think we are progressing further. So I think we will get there ultimately. Excellent. I would like to now hand over back to our next 6-2 crew member to introduce our last speaker.
Awesome. Thank you so much. I have the pleasure of introducing my very own division chief, Dr. Joseph Flynn. He is a professor of pediatrics, Dr. Robert O. Hickman Endowed Chair here at Seattle Children's Hospital. Dr. Flynn has a long-standing interest in childhood hypertension, including neonatal hypertension and the cardiovascular complications of pediatric chronic kidney disease. He chaired the 2017 American Academy of Pediatrics guidelines on high blood pressure in children and adolescents. And as I typically tell my patients, as I'm seeing them when we're on service together, he is the guru of hypertension. So here he is.
Yeah, but I think as a neonatologist, I'm an interloper. All right, let's get my talk up. All right, so today we'll talk about hypertensive neonates. You all have seen the learning objectives. First, to appreciate the influences on and determinants of blood pressure in neonates. Second, to recognize the major causes of hypertension in neonates. And then third, to develop a diagnostic and management approach to the hypertensive neonate. So normal blood pressure in infancy is complicated. It depends on a variety of factors, and some of which are listed there. Birth weight, gestational age, post-menstrual age, various maternal factors, which I'm not going to have time to get into today. Birth weight and gestational age appear to be the strongest determinants of blood pressure at birth. And then after the first 5 days of life, post-menstrual age appears to be the strongest determinant of blood pressure. And I'll show you some of the data that supports those statements. So there have been a variety of studies of cohorts of neonates in which blood pressures were measured and from which various algorithms and so forth have been developed. One of the most robust was the Philadelphia Neonatal Blood Pressure Study, which was conducted in the 90s. 14 NICUs in and around Philadelphia with 9,000 infant records and 24,000 blood pressures. And as you can see on the right-hand side of the slide, there was a correlation of both systolic and diastolic blood pressure with gestational age, so that with increasing gestational age, blood pressure was higher, and they were able to generate even regression equations for these lines, which you can see on the slide here, but clinically, I'll tell you, probably no one uses. Birth weight is another important determinant of blood pressure. And so there are a whole variety of studies that have looked at that, which are listed there. Going back to Julie Engelfinger in the 80s and through a variety of other studies that you see listed. On the right-hand side of the slide are the graphs that were generated by the Philadelphia study group, and you can see again as birth weight increased across the x-axis there, blood pressure was higher, both systolic blood pressure at the top and diastolic blood pressure at the bottom. And then blood pressure changes after, so that's the first day of life, right? And so after that, blood pressure changes. It starts to go up. And this phenomenon has been known since the 70s, where even using Doppler, a technique that I do not recommend, systolic blood pressure rose for the first few days of life, particularly up through the first week. And then you can see here that MAP increased with age and with postnatal age. And then you can see on the next slide that there were other studies using other methods of measuring blood pressure, that there was an increase over the first week of life here in term infants on the top, and then also in preterm infants in the second study by the same group of investigators. And here is the graphs that were published from the Philadelphia Blood Pressure Collaborative, not as pretty as the other one, sorry, but you can see that the blood pressure increased over the first 5 days of life, and they divided it up into tranches of gestational age, because as we already have seen, blood pressure was higher based upon gestational age. And what you see on the left is systolic blood pressure, on the right, diastolic blood pressure. Then after that, blood pressure continues to go up. We know blood pressure is a phenomenon related to growth, and that's true in infants as it is in older children. And so here are graphs of blood pressure and post-menstrual age after the first 5 days of life. And you can see that as post-menstrual age increases, blood pressure went up, and the rate of rise is listed there. There was another study a few years later from the Neonatal Nursing Initiative that showed the same thing, that blood pressure does tend to steadily increase with increasing post-menstrual age, and then sort of stabilizes at about 44 weeks post-menstrual age. So if you put all this together, there's a lot of more studies that we could talk about, but what Janice Dion has done with this graph, which I think is very helpful, shows that, you know, blood pressure starts out at a certain point, and then at the first few days of life goes up rapidly, and then has a more slower rate of rise as the infant approaches full term, and then after term, as the infant continues to grow. Now, moving from that on to diagnosis, let's, of course, talk about blood pressure measurement, because no talk on hypertension would be complete without talking about how to measure the blood pressure. And here you see a happy little baby who's all swaddled up and having their blood pressure taken while sucking on a pacifier. And notice that the cuff is in the right upper arm. Okay, so what are the recommendations for measuring blood pressure in infants? So we like the babies to be supine. All the standards are based on upper extremity readings. And so we really do recommend upper extremity readings. Now, that said, there are data, at least 1 or 2 studies that are pretty old now, but pretty clear that half blood pressure readings can be quite equivalent to brachial blood pressure readings for the first 6 months at least, maybe a little bit. After that, leg blood pressures become much higher. This is one of the reasons why diagnosed coarctation of the aorta in a neonate, 4 extremity blood pressures do not suffice. You have to do an echocardiogram. So because of that, though, and because the data come from upper arm readings, we recommend using upper arm. Try to use the same extremity for all readings, which if there are any nurses watching this, they're probably laughing when I say that, but it's for consistency's sake. Document what extremity was used, and then document what the infant was doing. Were they awake or were they asleep or what have you? There are various ways of measuring blood pressure. As you know, indwelling arterial lines are the gold standard for measuring blood pressure at any age, including neonates. You can use a radial artery or an umbilical artery catheter for that in a neonate. Doppler only gives you the systolic blood pressure. And so because of that, we don't really recommend that, because you can't even calculate a map based on just the systolic, but it is supposedly easiest. And then the oscillometric method, which the Dynamap is one brand actually of device, or one type of device, has some inaccuracies. It does rely on having a proper cuff size. So as we've said, direct measurement is the gold standard, and you all know this. I'm sure there's lots of neonatologists on the Zoom where you utilize it. You know that it utilizes a fluid-filled catheter system. You have to have the waveform just right. This again is why it's important to have skilled bedside nursing. There can be some sources of error with this, air bubbles. You have to maintain the transducer in the right spot and all that. But all that said, it is the gold standard. And other methods of blood pressure measurement are actually compared to it. Oscillometric devices. So how does that actually work? So what happens is, as the blood pressure cuff is released, the arterial wall oscillates or vibrates. And the oscillations of the vessel wall are transmitted to the cuff, and the patterns change as the cuff pressure is reduced. And based upon the pattern of oscillations, what an oscillometric device gives you is the map. Okay, the map is the only thing that an oscillometric device actually measures. From that, the software in that little box estimates the systolic and diastolic blood pressure. And there are different algorithms for that estimation, which vary from manufacturer to manufacturer, which is why it is impossible to have normative blood pressure data based on oscillometric readings in older children, but that's a whole nother talk. The problems with this are that, as I've said, the formulas are proprietary. They're not instantaneously displayed. So if you have an arterial line, that blood pressure value, you can see it fluctuate moment to moment. In the Dynamap or whatever brand device you're using, it takes a minute for that to be displayed. Any movement or activity can cause problems with the measurement. You've all experienced that clinically, I'm sure. But the one thing about oscillometric devices that are really great are that they're useful for following trends. And that's why in a pinch, if you don't have an arterial line, you can put an oscillometric device on the patient and program it to take blood pressures every couple of minutes, and therefore get a good idea of the trend in blood pressure over time. There have been some studies that have looked at oscillometric versus arterial blood pressures. This one is about 10 years old, but it's still a good one, by my friend Doug Blowy, who looked at, tried to correlate intraarterial and oscillometric blood pressure measurements. And you can see their pretty little graphs there on the side. You can see that the lines are not the same, right? So the solid line is the line you would get if the oscillometric and the arterial blood pressures were exactly the same, but you don't get that. You get a little bit higher for both for systolic and diastolic. If you look at this graph very carefully, you'll see that the difference is largest at the lower levels of blood pressure. So if you have a critically ill baby who has very low blood pressure, the last thing you want to do is measure their blood pressure with an oscillometric device, because you're going to overestimate their blood pressure and not get an idea for how sick they are. You need to have an arterial line when the baby's really sick. Now, remember I said that baby that I showed you the cute little picture of was sucking on a pacifier. Why is that important? It's because things like sucking on a pacifier actually change the blood pressure in a neonate. And this is a really interesting graph that came out of a paper that wasn't actually designed to look at this, but I thought that there was one table in their paper that was really interesting. So I made this graph. The black bars are systolic blood pressures. The gray bars are the diastolic blood pressures. And you can see there's some variability, right? Between babies who are deeply asleep or babies that are crying or active, and things like feeding the baby or giving the baby a pacifier to suck on actually also can increase the blood pressure. Now, most of the time, it's not a big difference. You can see there it's probably only 5 millimeters, maybe 5 to 10, but it is important to note what the baby is doing when you measure the blood pressure. All right, so in older children, we talk a lot about cuff size, and it is important in infants too. And here's another slide from Janice Dion, where she was part of a big collaborative, the name of which I forget right now, but they did a systemic review and meta-analysis of how to of measuring blood pressure in neonates. and came up with this sort of cartoon and this general rule that you should use a cuff with a width to arm circumference ratio of 0.5 so that the cuff actually goes around the arm completely and you get the most accurate reading. And then it's great to try to standardize blood pressure measurement if you're able to. And, particularly if you're evaluating a baby for hypertension, you want to know that the blood pressure was actually measured in a reliable way. This was a protocol published, a long time ago now, where they standardized the approach to measuring blood pressure, a symmetric device after a feeding, lying prone or supine, right size cuff, right upper arm, put the cuff on, then leave the baby alone, and then take the blood pressure a few minutes later. And then to do repeat readings because you can then average them to get a more accurate reading. All right, now how do we define hypertension? After all that measurement talk, how do we define hypertension in neonates? So I am going to tell you that I do not know the answer to that question. Now, I do not really know how to define hypertension in the patients that you all are taking care of. So that said, let me just run through the next couple of slides. So, in older children, we define hypertension as a blood pressure reading that's greater than or equal to the 95th percentile for age, should be biologic sex, not gender, and height on 3 or more occasions. Well, that's all very well and good, but in neonates, this is not a constant number. It's always changing. I think this is why it gives us pause when we're trying to define hypertension. How do we do it? Do we use that post-menstrual age? Can we come up with percentiles? Do we use the 95th? Do we do the 99th? And, do we actually have robust enough normative data? And this is where I think an even bigger problem comes up, is that the data are not very robust to do what's listed on my third bullet there, to consult a standard table or graph. Now, we made one though. So a few years ago, Janice Dion and Carolyn Abbott-Ball and I wrote this review, and we went and tried to collate all of this available data, and we came up with what we thought were appropriate reference values for infants starting at 26 weeks post-menstrual age through 44 weeks post-menstrual age at the top. We estimated the 95th and 99th percentiles. Let me repeat that. We estimated the 95th and 99th percentiles because there really haven't been large enough studies to measure them in a reliable way. And we developed these tables. They were published in 2012. And actually, lo and behold, when we put together the guideline in 2017, the group of us experts decided to endorse the use of those tables because there's nothing else really out there. But we said that they were reasonable to use. We did not strictly define hypertension. I think you could maybe say that if the blood pressure is really above the 99th percentile on this table, probably abnormal in that baby and probably worth some special attention. Now, but like I said, I'm not going to give you a definition of hypertension. I'm just going to say that those are values that are of concern. Now, obviously, if the baby has congestive heart failure, they have hypertensive encephalopathy, well, that's an abnormal blood pressure reading, and you need to act on that. All right, so in terms of diagnosis, there's your table. I could spend the next 2 hours going through this table. I am not going to do that. I'm going to talk just about a few of the major causes that are in red there, including thromboembolic disease, kidney disease, lung disease, and various medications. So and I'm going to talk about those things by going through a couple of illustrative case series. So this case series came from Australia, where they looked at infants admitted to a NICU there over a period of 4 years. They identified 34 babies as having hypertension. And noted that those babies tended to be more premature, had lower birth weight and length, which probably goes together, than infants without hypertension. And you can see there that the babies who were hypertensive were a bit younger in gestational age and lighter and shorter. They found that the diagnosis of hypertension wasn't made until day 5 of life. That, in other words, it wasn't something they saw right away. It was something that they noted after the baby had been in the NICU for a while. They noted that babies with hypertension had, a GFR of 38, which probably for neonates not that bad, right? And that many of them had abnormal kidney ultrasound findings. Many of them had abnormal aldosterone and renin. And they found that factors associated with hypertension included acute kidney injury during the admission and the presence of an umbilical artery catheter. Fast forward a few years, this is a case series from, I think, Texas, where they looked at systemic hypertension, oh yes, Houston, in preterm and term infants, and they noted a few things about the babies who were hypertensive. So they saw that the major causes were respiratory disease, iatrogenic causes like caffeine and dexamethasone are being put on ECMO, and then kidney disease were the most common causes of high blood pressure, or the most common conditions associated with what was diagnosed as hypertension. How's that for a convoluted phrasing? In the infants, according even these different gestational age groups. And they again showed that some things that were important were having bronchopulmonary dysplasia, receiving steroids for bronchopulmonary dysplasia, and then also having a PDA and getting indomethacin for a PDA. So some of the medications given to correct problems that these babies have end up causing the blood pressure to be higher. Now, moving on from diagnosis, differential diagnosis, how do you make a diagnosis, or what do you think about when you're evaluating these babies? Well, you start with history and physical exam, look at prenatal exposures, maternal diabetes and other maternal health conditions. Dr. Kent has actually published on maternal health conditions and infant blood pressure. What happened in the NICU, in the L&D suite, nursery, what's been going on with the babies since they were born, what kind of procedures have they had, what kind of medications are they getting. You're going to do everybody's going to do the floor extremity blood pressure readings, but remember what I told you about coarctation. If you think that might be it, you need to do an echocardiogram. Other things, does the baby have normal genitals? Do they have other dysmorphic features that would make you think about a genetic condition like Turner syndrome, for example? Do they have a big right upper quadrant mass and have an obstructed kidney or a tumor of some sort? So those are some of the things that you would want to look at. The lab tests that are needed are not so many. I find that oncologists and neonatologists order more labs than nephrologists. So usually when I go to see these babies, most of the labs I want have already been done. They're listed there. We would do also potentially a chest x-ray. They all need a kidney ultrasound, and neonates is the one age group where Doppler is useful. Outside of neonates, a Doppler is not useful, but that's another talk. And then other studies, if you think you need them, things like different hormones, that are listed there, echocardiogram, other kidney imaging, and so forth. But not every baby needs all those things. How about therapy? So first of all, make sure you address iatrogenesis imperfecta. So stop the steroids if you can, cut back on the fluids if you can, correct the hypercalcemia if that's there. Then, if the baby seems to have pain, make sure that's treated. So those are just some general things to look at. What's being done to the baby? Could that be causing the high blood pressure? And then how about antihypertensive medications? Well, this is a very interesting question that probably you're all going to hit me with during the Q&A session, because I'm not going to give you an answer. Obviously, if the baby has symptomatic hypertension like congestive heart failure, you're going to, treat that baby right away. But what do you do? So this is the call, and Caroline can probably tell you, this is the call we get from the University of Washington NICU. Hello, Dr. Jackson. We have a baby who is now a 3-month-old former 24-week preemie, and we've noticed that the blood pressures are above a certain number, and should we treat the baby with a blood pressure medicine? I'm sure Caroline has gotten multiple calls a bit like that. And, I think it's an interesting question, and I'm not quite sure of the answer. And I think maybe if the baby's blood pressure has really been above that 99th percentile for a period of time, it might be worthwhile to treat. And I had a very interesting meeting the other day with a researcher in Alabama, David, you may know him, who is interested in neonatal hypertension. And he said, Dr. Flynn, what are the outcomes we should be looking at in infants to know whether they should be treated, or what are the things? Why would you think about, treating a neonate with antihypertensive medication? And I said, well, good question. I guess it's because we think that sustained elevated blood pressure is unhealthy. And we sort of are taking a life course approach, and maybe that baby is going to stay hypertensive for their lifetime, and therefore they are going to develop complications of hypertension. And so we're trying to be good citizens and protect the baby in terms of their cardiac status, their kidney status, and their brains against the effects of high blood pressure. Remember that the kidneys for many of these babies are still developing. the brains are still developing and easy to injure. And so perhaps for those reasons, we would start a blood pressure medication. But I think, that he asked me a very good question, and I'm not quite sure of the answer. Now, Dr. Kent and Matt Harrer, who might be on this call, I don't know, published this table of what they thought was reasons to treat. And you can, download that paper. And they basically said, if the baby has kidney disease, you should treat. And as a nephrologist, I would agree. If the baby has blood pressures above the 99th percentile, you should treat. And I guess maybe that's reasonable. And obviously, if they have a hypertensive emergency, like would basically congestive heart failure would be the one probably most likely seen you should treat. So, I think this is a reasonable approach. But, it's all empiric because there have been no clinical trials of antihypertensive medications conducted in neonates ever. So everything that we do is based upon sort of adaptation from what we learn in treating older children. We know that just as in older children, if there is a hypertensive emergency and the hypertension is symptomatic, you should use an IV medication because you can control the blood pressure reduction a little bit better. And then if the blood pressure is high, but not that severe, and the baby's not symptomatic, you can probably use an oral medication. And there's all sorts of considerations like, are they getting fed? Do they have neck? All those things that you neonatologists know better than me. Now, one point I do want to make is about blockers of the renin-angiotensin-aldosterone system. Should they be used in neonates? No. So normal kidney development depends on an active renin-angiotensin-aldosterone system. We know from multiple case reports in the literature that neonates are very sensitive to RAS blockers, and you put them on one and you're going to drop their blood pressure down quite rapidly. We know that when there are mutations in the renin-angiotensin-aldosterone system, you get something called renal tubular dysgenesis, which is unhealthy. And we know that if mom took a RAS blockade during her pregnancy, you get ACE inhibitor fetopathy. So expert opinion says don't give them until you think that kidney development is complete, which I will say is 44 weeks post-menstrual age. And if you look at this, so I want to just show you some trends over time. I think the message is getting through. So Doug Blowy published another study in 2011 where he showed what drugs neonates who received treatment got. And at that point, 50% received ACE inhibitors. A more recent study, and you can see that there, with vasodilators, angiotensin blockers, and calcium channel blockers. Okay, I know I'm running out of time. A more recent study just published this year looked at classes of blood pressure medication use, and now RAS blockers, now calcium channel blockers are the most common, and RAS blockers are the least commonly used medication. So the message has gotten out. And then what about after discharge? So what drugs can you use? You can see those listed there, channel blockers, beta blockers, etc. They need post-discharge monitoring of their blood pressure. They need to have their blood pressure measured at home. If you do not already have a system, you need to put into place a system for getting your patients with your neonates with hypertension home Dynamaps. And if you don't know how to do that, Caroline can put you in touch with Susan Hallback at our institution, where we've worked that out. You need to do laboratory studies if they're on diuretics. We usually monitor their kidney growth over time with repeat imaging, and most will outgrow the need for medication. And I can say that finally, we actually recently published data on this. I didn't put the graph in this talk, but we just have a paper that came out in Journal of Pediatrics that showed that by 2 years after discharge from the NICU, almost every baby who is discharged on medication is no longer on medication, which should be, I think, helpful when you talk to families about outcomes. So to sum it all up, multiple factors affect blood pressure in neonates. It makes it challenging to evaluate these babies. It makes it challenging to develop a standardized definition of hypertension. It makes it challenging to know when to start treatment. There's a differential diagnosis is very long. Start with the basics and then add things as you need. Have to measure the blood pressure carefully, and the management is empiric. And with that, I am finished, and you can hit me with your questions. Thank you for your attention.
Thank you, Dr. Flynn. It's always wonderful to hear your talks about neonatal hypertension. What is your sort of management for the baby that is acutely unwell with hypertension? I guess that's the one situation where, as a neonatologist, we have maybe watched the blood pressure, been a little bit concerned, and then the baby's actually collapsed with failure. How do you manage those babies?
For those babies, and typically what they're experiencing is something that leads to congestive heart failure. Those babies need to be on a nicardipine infusion. That's our recommend. That seems to be the standard approach for treatment. The other, and there's actually pretty good, well, case series data, but on nicardipine in neonates. The other drug that people will use is labetalol. I hesitate to recommend nitroprusside in neonates given their reduced GFRs, although, you know, maybe for like a day you could use it. And I have no clue as how to dose esmolol, which is the other IV drug that people will often use in a hypertensive, in that sort of situation. So I think most of the time we would recommend nicardipine. The drugs I would never use would be IV enalaprolat and IV hydralazine. They are dangerous medications that I would not recommend being used.
Excellent, thank you. Does anybody else on the panel, any of our 6-2 crew, have any questions for Dr. Flynn?
Well, I do have the benefit of having lots of opportunities to ask questions, but your talk made me think of one, Dr. Flynn, mostly about follow-up plans, because we do get those calls as well. And should these babies who are treated for hypertension or just have sustained hypertension in the NICU be followed by nephrology, or can their PCP follow them, since most of them are going to outgrow it? When should we see them? And then is there any data that shows if they're at higher risk for like masked hypertension in their younger childhood, after even off medication? Should we be doing ABPMs on these kids if they have a history of this, that sort of thing?
I mean, it's a good question. I mean, I think that when we talk to primary care doctors and say, hey, can you measure this baby's blood pressure for us? 99 out of 100 times the office is not capable of measuring blood pressure in a neonate and or in an infant. Not they wouldn't be neonates any longer. So because they don't have the equipment. And so that sort of then puts it on a specialist, whether it's through a nephrology, hypertension clinic, or, if you had a robust neonatal follow-up clinic where you could, see those babies and arrange for the right kind of equipment, then I think the follow-up's going to end up being in the hands of a specialist. Do they develop masked hypertension or hypertension later in life? It's a really great question. I mean, I think as I sort of alluded to, these are usually the sickest of sick babies. Many of them have been born prior to the completion of nephrogenesis. Carolyn Ebbetball's group has shown that many of these babies will never develop a normal complement of nephrons. And so they probably have reduced nephron endowment and are definitely at risk of hypertension later in life. And I think, it's not unusual for people who like run pediatric hypertension clinics who you get, usually you see sort of the teenager with some overweight who comes in with high blood pressure, right? But every so often you get a skinny kid with a skinny teenager with hypertension, and you find out that they were 28 weaker. And that is actually a real thing. And I think that we, ideally we would follow these kids and maybe do, some monitoring for masked hypertension, in a perfect world. Problem is, we don't live in a perfect world. We don't live in a country, in the US at least, where you can actually, where people stay put. And you can bring them back to the same institution. And so it becomes, quite a difficult problem.
Thanks, Dr. Flynn. We've got a question from Marwa Abdul Karim, who's asked, can you explain more why IV hydralazine is very dangerous in treating hypertension in neonates?
So, well, first of all, there's no established dose in neonates, like for everything else. And secondly, it lowers the blood pressure in an unpredictable manner. So you might get the blood pressure to drop as much as you are intending, but we've published data showing that up to 30% of the time, the blood pressure falls more than you want. Now, that was not in neonates, but if that's what you're getting in older children, then, I can just imagine what would happen in neonates. And, these babies don't have mature, their brains are not normal. And so if you bottom out their blood pressure, then you could have, adverse consequences of that. So I feel pretty, the next drug I want to get, I got K-Xylate removed from our hospital formulary. I accomplished that last year. And this coming year, my next goal is to get hydralazine removed from our hospital formulary.
Excellent. We do have now all speakers are available for questions. There was a question earlier from Andrea Casso, who wanted to know from Kat Gist in particular, I think with how much IV fluids do you start with in an extremely low birth weight infant? And if anyone else on the panel wants to comment as well, that would be great.
I'm going to defer mostly because I don't take care of extremely low birth weight infants, other than to say that I would usually start with 60 mLs per kilo per day in a preterm infant, but I'll let the neonatologists speak to their expertise.
I think it's actually a really hard question to answer, and I think it also then depends on how much humidity that you're using, and I think it then also depends on the gestation of the baby. I think our 22, 23-week gestation population is extremely different to the 26 or 27-weeker, and even perhaps from the 24 and 25-weekers. So I think that probably most of us would start at around 80 mils per kilo per day in our very preterm babies. And even with the 22 or 23-weeker, it may even be sort of 90 mils per kilo per day, given depending on whether they've had antenatal steroids and what the keratinization of their skin looks like and how fragile their skin is looking. So it does make it a big challenge. And I think one of the things that's interesting is when you look in the literature, there's not a lot as to what we should start with our humidity at. And I think perhaps we also need to be thinking with our 22 and 23 weekers, do we need to have higher humidity in comparison to a 25 or 26 weeker? But I'd be really interested to hear what the rest of the panel think as well.
So we have now early fluid management guidelines related to reducing our fluid intake in those less than 1,000 grams and those greater than 1,000 grams. So we started about 80 mLs per kilo per day for those less than 1,000 grams and 60 mLs per kilo a day for those greater than 1,000 grams in like the early fluid management for 26 weeks and kind of up to the 1,500 gram mark, and then adjust from there. It's interesting though, because those are based off of like prevention of chronic lung disease and allowing for some diuresis postnatally and making sure we don't flog them, but kind of what happens as a consequence of that. You know, do we dry them out too much? It'll be very interesting to see, because like we've said, there's not a lot of great evidence out there, and what it does exist related to this, it's very rare that the kidneys are looked at as a consequence. I think that dynamic is changing, and I'm very excited kind of for the next 10 years to where we go as a field. But just that, and that's just CCHMC protocol. So, you know, there are various places across the US that start differently. And then you do, like Allison said, have to take in the condition of the skin, how much fluid loss you're losing from thermoregulation and other things as well.
Excellent. Any other questions from our 6-2 crew for Dr. Flynn or any of our other speakers? Excellent. It doesn't look like we've got any extra questions online from anybody.
Allison, I have a question for Dr. Flynn. So can you help me understand why neonates are the only population that I know of where their hypertension just goes away? What are some of the possible reasons why you think that's happening?
One possibility is that it was incorrectly diagnosed.
Sure.
And they never really were hypertensive. And that relates to some of the uncertainty I talked about normative data and maturation of blood pressure and so forth. The other possibility is that the initial high blood pressure is really a reflection of sort of an acute process in the kidney that then resolves over time or heals. And so if you look at some of the studies that relate to thromboembolism, for example, where people actually demonstrated pulling out the umbilical catheter led to, clots being dispersed into the kidneys. And so were those areas of ischemia that then led to some higher blood pressure, and then eventually over time, those areas either scarred down or healed or whatever. And so that stimulus for the high blood pressure goes away. Or, the other group is babies with bronchopulmonary dysplasia and chronic lung disease, where I think the theory of why they become hypertensive is from hypoxemia. And so then do their lungs mature, and they then sort of get better from a pulmonary standpoint, because we know that even babies, not every baby with BPD is going to have a lifetime of chronic lung disease. So, do they get better? And again, the stimulus for the high blood pressure goes away, and then the blood pressure is now normal. And then finally, do the kidneys finally finish maturation, and they are able to overcome the damage to a small amount of kidney tissue, because those more superficial cortical nephrons have now matured and are bigger and are taking over and providing better function. I mean, it's all theoretical, but those are some theories that I can sort of come up with.
Great, thank you.
I'm going to piggyback off of David's question, although this is more of a comment too, because one of the things that I feel like I notice is that some of our infants with BPD who have some underlying pulmonary hypertension also have slightly elevated blood pressures. So with that, like the need for the lungs to mature and the blood pressures to get better, do you think some of that could be a compensation of, one of the ways that we work around pulmonary hypertension, right, is to get their blood pressures even higher to help perfuse. And so is it the body's way of trying to kind of compensate for that? I don't know.
Good question.
I think that's the challenge with the BPD babies. I think it's probably useful to have an echo at that time and assess what their right-sided pressures are to determine whether the higher blood pressure is trying to achieve a decent flow to the lungs. So I think they're the sort of challenging ones as to whether you treat those ones or not, whereas the babies who have hypertension but without significant lung disease, it sometimes is a little clearer. Excellent. Jennifer, I think we're probably almost at the close. Did you want to make any last comments?
On the struggle bus with Zoom, even this far into post-pandemic time. First, we get to announce the winners for the free registration to the NICS course. These were chosen randomly through some very sophisticated technology that I don't know, but Megan Reagan does. Tony Lercata, I guess this is New York Presbyterian in Columbia, I'm guessing, hopefully that's right, and Prakash Rao from Hospital Kanangao. So congratulations, very exciting. I think, I don't know if Megan's on and wants to say more about how you can get these registrations, or David, if you know what they need to do to claim their prize. Happy for you to share.
Yeah, call Megan. Yes.
Yeah, well, I'll reach out to the individuals and give them their free registration comp link, so they're good.
Yes. In life, calling Megan is generally a good strategy because she gets things done for sure. All right, so I think that is all we have today. Thank you so much to our speakers, Dr. Gist, Dr. Josephs, Dr. Slagle, and Dr. Flynn. I always learn so much from all of you, and I've very much appreciated getting to know you over the years as well. And thanks to our 6-2 crew members, Dr. Deitmeyer, Dr. Jackson, and Dr. Bondarev. It's been a pleasure having you help out today. Most of all, thank you to all of you for attending and for the work that you do every day to take care of your patients and their families.